think it's a pleasure to be at this meeting here. We're talking about IOL classification. This is a topic which has been a huge interest over the last years, and the reason is all these companies all over the place here have different IOLs, and we need to categorize them. We as physicians need to find a way through this jungle of IOLs, which one is what, and that's the reason why we put together this classification.
The new European functional lens classification, I think, helps a lot for me as a surgeon and my colleagues. Someone else has done the hard work to really analyze what's in the literature to describe and better define the true function of different lens designs.
Now, my talk is going to be about being a little more clinical perhaps, which is to look at the lenses that we have and how they might fit with different categories according to this new classification system. But it's very significant that we as surgeons have tools to help us choose a lens for our patient. And of course, being able to better understand their performance is useful.
For example, we may take a lens like the FEMTIS, for example, and then in the dominant eye, use the FEMTIS 15, the FEMTIS Comfort, and the non-dominant eye, the FEMTIS 30, which is the higher powered version. So this is a slightly different use of the lens as compared with what the functional classifications tell us to do. But we know that in the real world for that patient, it will help fill out the range of vision and still minimize their unwanted visual phenomena.
I use a very typical system, I would say even an easy system, to demonstrate what you can get, what you will get with a monofocal. And I have a picture in my practice in the University Hospital in Frankfurt, where you basically look at the distance. On this picture, you cannot see the dashboard at a car, and you cannot see an iPhone, for example. And then the next picture is where we have only the iPhone not clear. That's an EDOF. And then we have a picture where everything is clear. And then we show it to the patient, and they understand. You have to use easy terms, because the patients come already with so much information, they are confused. And I try to simplify it, and then I try with all the examinations we have done, with the talking to the patient, to figure out what is the best solution for him.